Welcome back to Deep Dive Ortho. Today we're tackling a subject that really pushes the boundaries of orthopedic surgery, revision, total elbow arthroplasty, especially when you're up against significant, massive bone loss. It's often the last chance saloon for patients, isn't it?
It really is. A challenging area, no doubt about it.
We're going to explore why fixing a failed primary elbow replacement, a TEA, is so uniquely complex. It's not just a simple swap out. It brings a whole host of diagnostic and surgical headaches. Our mission today is to give you, our listeners in practice, some real clinical insights. We'll cover the indications, the diagnostic maze, the surgical techniques that are making a difference, and what happens to these patients long term.
Looking forward to it.
And guiding us is a leading voice in the field. It's a real pleasure to have you with us for this deep dive.
Thank you. Happy to be here. It's a critical topic, and understanding the nuances is vital for anyone dealing with these incredibly difficult cases.
Absolutely. So let's jump right in. Why is revising an elbow replacement so much harder than the primary operation, or even revising, say, a hip or a knee? What makes the elbow such a, well, a special case?
That's a great place to start because it really gets to the core of the difficulty. The elbow, it's just built differently. Compared to the hip or knee, which have quite a generous covering of muscle and fat, the elbow's soft tissue envelope is remarkably thin. Think about the skin stretched right over the olecranon, the pointy bit.
Yes, very little padding there.
Exactly. So wound healing can be precarious, especially after multiple surgeries. There's less tissue protection, higher risk of breakdown. And then crucially, you have the major nerves and vessels packed in incredibly close to the joint.
The ulnar nerve, the radial.
Precisely. They're right there. So every move you make during surgery carries a risk. Damaging one of those structures can be devastating for hand and arm function. It's an unforgiving environment. And biomechanically, it's not just a hinge. It twists. It turns pronation, supination. Trying to reconstruct that intricate balance after a failure, especially with bone missing, is exceptional tough. It's inherently less stable than, say, a hip joint.
So it's the anatomy, the biomechanics. And I gather the failure rates themselves are higher to begin with, compared to other joints.
That's right. The numbers really tell a story. For primary TEA, you can see early complication rates quoted as high as, well, up to 24% in some studies. That's quite stark compared to lower limb joints. And the overall lifetime chance of needing a revision for a TEA is around 13%.
13%, that's significant.
It is. Compare that to hips and knees, where we often see survival rates well into the 90s for 10, 15, even 20 years. Elbows, while they might hit 70, 90% survival at 10 years, that figure can drop off, maybe down to around 60, 61% at 20 years. It tells you straight away that primary TA isn't always a one-and-done procedure like we sometimes think of for hips or knees.
So the message for clinicians is expect revisions, potentially.
I think you have to, especially when counseling patients, particularly younger ones. The likelihood of needing further surgery down the line is just higher with elbows. It needs to be part of the initial conversation and the long-term thinking.
That's a key point. And what about the patients themselves? Has the type of person needing these operations changed? Is that adding to the complexity?
Yes, absolutely. That's been a major shift. Historically, the typical primary TEA patient was older, often with severe rheumatoid arthritis. The goals were mainly pain relief, maybe restoring some basic daily function. But now we're seeing a real increase in demand from younger people, often working age, and frequently they have post-traumatic arthritis. So they've had a bad fracture or dislocation years ago, and now the joint is destroyed, often with significant bone loss right from the start.
And for them, a non-functioning elbow just isn't viable.
Not at all. Think about it. If your elbow is unstable, floppy, or you can't bend or straighten it properly to get your hand where you need it for fine motor skills, for work, for basic tasks, it drastically impacts your independence, your ability to earn a living.
So the functional demands are much higher.
Much higher. They need durable solutions that can withstand more activity. This shift really magnifies the need for effective revision strategies that can truly restore function, not just mask pain.
It sounds like there was a real gap in treatment options for these complex cases for a while. You mentioned a clinical void.
There absolutely was. For a long time, if you had massive bone loss after a failed elbow replacement, the options were grim. Very limited prospects, and sometimes, yes, amputation was seriously considered. It was this pressing need, this gap, that really drove pioneers like Dr. Bernard Mori and later his son, Dr. Mark Mori, to tackle these exceptionally challenging problems.
They really dedicated themselves to finding solutions.
They did. They weren't afraid to take on the cases others might have turned away because there just wasn't a clear playbook. It was about finding ways to salvage these limbs, even learning from the difficult early experiences with things like allograft prosthetic composites, which had high complication rates initially. That drive to find answers for patients with seemingly insurmountable problems is really what pushes surgical innovation forward.
It's quite inspiring. Okay, let's shift gears slightly and break down why these primary elbows fail. What are the most common reasons someone ends up needing a revision?
Understanding the why is fundamental to planning the how for the revision. The number one reason, accounting for about 15% of primary failures, is aseptic loosening.
So the implant just comes loose from the bone without infection.
Exactly, it gradually detaches. This can be due to wear and tear over time or perhaps the joint being overloaded. Sometimes it's mechanical, like the coronoid process on the ulna bumping against the front of the humeral component during flexion anterior impingement, which levers the implant loose. Certain factors seem to increase the risk, like some older cementation techniques or highly constrained implant designs that transfer more stress to the bone-implant interface.
15% is quite a chunk. What about fractures happening around the implant? That must be a nightmare to deal with.
Periprosthetic fractures are definitely a significant challenge. They happen in maybe 5–6% of primary TEAs, but that jumps up to around 15% in revision surgeries.
15% in revisions, wow.
Yes, it shows how much more fragile the situation is after the first surgery. The main culprits are usually bone loss around the implant osteolysis, or the implant already being loose, or just pre-existing poor bone stock from the initial injury. We use the Mayo classification to help categorize and manage these.
How does that help practically?
It gives you a framework. Type I are for fractures near the joint ends. Type 3 are well below the implant stem. It's the Type 2 fractures along the stem that are often most relevant to revision, particularly at Type II3 that signifies severe bone loss alongside the fracture. If you see that classification, your mindset immediately shifts. You're not just fixing a fracture anymore. You're planning a major reconstruction, likely involving significant bone grafting and complex revision techniques.
Got it. And infection. Always a major worry with any joint replacement, but perhaps even more so in the elbow.
Infection, or PJI prosthetic joint infection, is a huge concern in the elbow, yes. Historically, rates were worryingly high, maybe up to 9%. Thankfully, with better techniques and things like improved management of rheumatoid arthritis with DMARDs, more recent figures are lower, perhaps around 3%, but that's still considerably higher than for hips or knees.
Why is it so much more difficult in the elbow?
Several reasons. That thin, soft tissue envelope we mentioned makes surgical debridement, cleaning out the infection, harder. There's just less tissue to work with, and achieving a clean margin is tough. Then there are the bugs themselves. Staphylococcus aureus is the most common, about 40% of cases, but Staphylococcus epidermidis, a coagulus-negative staph, accounts for another 30–35%.
And S. epidermidis is particularly nasty.
It's notoriously difficult because it's brilliant at forming biofilms. Think of it like a slimy protective shield that the bacteria create around themselves on the implant surface. This biofilm makes it incredibly hard for antibiotics and even the body's own immune cells to reach and kill the bacteria. Having an S. epidermidis infection increases the risk of the infection coming back by about 3.5 times. It's a real headache.
Biofilms, a persistent enemy. Are there patient factors that increase infection risk too?
Yes, definitely. Patients with rheumatoid arthritis, especially if they're on steroids, are at higher risk. Hypothyroidism, diabetes, anyone with compromised soft tissues, a history of previous elbow surgery or infection, these all stack the odds against you. Even psychiatric illness can be a factor, sometimes impacting adherence to treatment plans. It all adds up to make PJI a particularly difficult challenge in elbow revisions.
That's a complex picture just on the infection front. Are there other ways these implants can fail beyond loosening, fracture, and infection?
Yes, there are. Instability can occur, particularly with some older, unconstrained designs, where stability relied heavily on the patient's own ligaments and muscles. If those tissues fail, or if there's significant bone loss, the joint can become unstable.
And the implant components themselves can fail.
They can. Component failure accounts for maybe another 15% of revisions. The classic example is bushing wear. In link elbow designs, there's a polyethylene bushing that acts as the bearing surface between the humeral and ulnar components. Over time, especially in younger, more active patients, or if there was significant deformity putting odd stresses on the joint, this bushing can wear out. It crumbles, essentially.
Like a bearing wearing down?
Exactly. That leads to instability, pain, and the joint not tracking properly. So that's another distinct failure mode we have to look for.
So it's not always just about the implant locally. How much do you need to consider the patient's overall health or problems in adjacent areas when looking at a failing elbow replacement?
That's a really crucial point. You absolutely have to look beyond the elbow itself. Systemic issues play a huge role. Diabetes, any form of immunosuppression, they compromise healing and ramp up infection risk.
Hmm.
Neurological conditions might affect a patient's ability to protect the joint or follow activity restrictions, leading to falls or overloading.
And local issues, too.
Definitely. Nerve problems, like ulnar nerve irritation or entrapment, can cause pain that mimics implant problems, or they can severely complicate recovery after revision. Muscle weakness or insufficiency, perhaps from previous surgeries or just disuse, compromises the elbow's stability and function. And then there's heterotopic ossification, that's abnormal bone forming in the soft tissues, which can cause stiffness and pain. So yes, a truly thorough assessment looks at the whole picture, the patient, the region, not just the metal and plastic.
That holistic view seems essential, which leads us nicely into the diagnostic process. When a patient walks in with a painful elbow replacement, how do you systematically approach figuring out what's actually going on? That outside-in assessment you mentioned.
Yes, the systematic approach is key. You can't just jump to conclusions. Broadly, patients present with either a stiff elbow, a weak one, or an unstable one. Pain is usually a common factor, and the specter of infection always looms large. The goal is to methodically work through the possibilities, starting from the surface and going deeper.
So, starting right at the surface, the skin and soft tissues, what are you looking for there?
We're looking really carefully at the skin's condition. Is it healthy, well vascularized, or is it thin, shiny, scarred from previous operations? We pay particular attention to the skin over the olecranon. Is it under tension? Is it adherent to the bone? Because that's a real pressure point and prone to breakdown. We assess the healing potential. Multiple old scars might mean trouble ahead for wound closure. We also check sensation, especially protective sensation over the olecranon. Any redness, warmth, swelling, or crucially, any sinus tracts, little draining openings, those are immediate red flags for infection.
And then moving deeper to the nerves, you said they're packed in tight. How do you assess them clinically?
Very carefully. We examine the main nerve trunks. Ulnar, radial, median. We're looking for clues of previous injury, maybe from the primary surgery, or signs of ongoing compression from scar tissue or bony spurs. Or maybe the nerve itself is intrinsically unhealthy. With the ulnar nerve, we specifically check if it's been transposed anteriorly before. We test for tunnel sign tapping over the nerve to see if it causes tingling, and assess if it's unstable, popping in and out of its groove. Underestimating existing nerve problems is a common pitfall. It might be the main source of their pain, or it might mean the nerve is very vulnerable during the revision.
Makes sense. And the muscles around the joint, what are they telling you?
The muscles tell us about the engine and the stabilizers of the elbow. We assess the key muscles around the joint, the collateral ligament equivalents, the muscles that help share load with the implant, like the anconeus, the flexor and extensor groups. We also look at the main power muscles, like the brachialis at the front and the triceps at the back. How is the triceps handled in the first operation? Is it intact? Is it strong? Because infection or multiple surgeries can really damage the triceps, leaving the patient with poor extension strength. Muscle health is vital for function and for protecting the revision implant.
Okay, so after the hands-on examination, imaging must be critical for seeing what's happening underneath. What are the key imaging tools, and what does each tell you?
Imaging is absolutely fundamental. We always start with plain radiographs, standard x-rays, AP and lateral views, getting the whole humerus and forearm in. We're looking for the obvious things like fractures, but also subtle signs of loosening around the components, any gaps or radiolucent lines. And we look very closely at the alignment between the components specifically. If the angle between the ulnar and humeral parts is more than 10 degrees, that strongly suggests the polyethylene bushing is worn out.
A key sign, that 10-degree angle.
It is. And another crucial point on x-ray. If you see loosening, especially early loosening, that doesn't have an obvious mechanical cause, you must suspect infection until proven otherwise. That's a major red flag.
What about CT scans? When do they come in?
CT gives us much more detail, especially about the bone. It's brilliant for seeing bone loss, osteolysis around the implant, for precisely assessing how loose a component is, and for checking the integrity of the cement mantle if it was cemented. For complex cases with big bone defects, we absolutely rely on 3D CT reconstructions. These let us really visualize the defect in 3 dimensions, plan exactly where grafts need to go, and even template for custom guides or implants.
And MRI, does that have a role?
MRI is less routine for assessing the implant itself because of metal artifact, but it's very useful if you suspect an abscess or a significant soft tissue infection. you often need special metal artifact reduction sequences, and contrast helps highlight inflammation and fluid collections. So each modality, X-ray, CT, MRI, gives us different complementary pieces of the puzzle.
So you've got the clinical picture, the imaging picture.
Yeah.
What about blood tests and maybe taking fluid from the joint? How helpful are they, particularly for infection?
They're essential parts of the workup, especially for infection. We run standard blood tests, ESR and CRP, the inflammatory markers, and a white blood cell count. Generally, ESR and CRP will be elevated if there's an infection, but they're not specific. Other things can raise them too. So you interpret them in context. Aspiration of the elbow joint arthrocentesis is often the next step.
Is there a specific cell count in the fluid that confirms infection, like in the knee?
Unfortunately, it's not as clear-cut in the elbow. There isn't a universally agreed-upon synovial white cell count threshold that definitively diagnoses infection. However, getting a positive culture from that fluid is generally very indicative of chronic infection, high positive predictive value. But, and this is really important, a negative culture does not rule out infection.
Low negative predictive value.
Exactly, especially with those biofilm-forming bacteria like S. epidermidis or low-virulence organisms. They might just not grow in the culture. So if your clinical suspicion is high, a negative aspirate doesn't give you the all-clear. Often the most definitive information comes from samples taken during surgery itself.
Intraoperative samples.
Yes, sending tissue samples around the implant for histology, looking at them under the microscope for inflammatory cells is very useful. It's got high specificity, meaning if it's positive, it's very likely infection, but its sensitivity isn't perfect, maybe only around 50%, so it can miss infections. We also take multiple deep tissue cultures during the operation. But again, even these can be negative in up to 10% of proven chronic infections, particularly if the patient has had recent antibiotics or if it's a tricky bug to grow. So diagnosing infection is often about putting all the clues together, clinical, imaging, labs, intraoperative findings. There's rarely one single magic bullet test.
It really sounds like detective work. How do you pull all that information together? You mentioned a kind of 3D model perspective.
That's a helpful way to conceptualize it. I think about the three key elements: the quality of the patient's bone stock, the status of the existing implant, is it loose, worn, well fixed, and the quality of the surrounding soft tissues. Skin healthy, muscles functional, nerves okay. Each patient sits somewhere in this 3D space, defined by how good or bad each of those three factors is.
So a patient might have terrible bone, but good soft tissues and a salvageable implant, for instance.
Precisely. Or maybe the bone is okay, but the soft tissues are dreadful after multiple surgeries and infection, and the implant is loose. Understanding where the patient falls in that 3D model tells you what the main challenges are and guides your surgical strategy. You can't just fix one thing in isolation. If the bone is poor, you need a plan for that. If the soft tissues are compromised, you need a plan for coverage. It dictates the complexity, the implants you might need, the likely outcome. The goal is to use surgery to improve the patient's position within that model across all three axes.
That's a really clear framework. Thinking about the surgery itself, things have obviously evolved. You mentioned the Mori's work. Can you talk a bit about the journey, maybe starting with those earlier allograft prosthetic composites?
Yes, the surgical journey has been one of significant learning, often from tough experiences. Dr. Bernard Mori's early work using allograft prosthetic composites, basically combining donor bone with an implant to bridge large defects, was truly pioneering. At the time, it seemed like a potential solution for massive bone loss, where options were few.
But it ran into problems.
It did. Despite the innovation, the results over time showed unacceptably high rates of complications, particularly infection, and the allograft failing to heal to the patient's bone non-union. The issues were significant enough that there was essentially a pause, a moratorium, on that specific technique while they reevaluated. It taught the field some incredibly valuable lessons about the absolute need for meticulous infection control and achieving solid bone healing in these incredibly hostile biological environments. Even tiny bits of old cement or dead tissue left behind could doom the reconstruction.
So, learning from that, how did the approach evolve? What did Dr. Mark Mori and his team change to get better results?
They fundamentally shifted the paradigm based directly on those hard lessons. The absolute #1 priority became eradicating infection before attempting major reconstruction. That often means a two-stage approach. First, surgery to remove everything, debride thoroughly, and put in an antibiotic spacer, followed by weeks of antibiotics, and only then, once the infection is cleared, going back for the definitive reconstruction.
Infection first. That's a key change.
Critical. Then came enhanced planning. Using detailed 3D CT scans to really understand the defect and plan the bone cuts and graft placement became standard. And a major step forward was the use of patient-specific 3D printed guides. These guides fit precisely onto the patient's remaining bone, ensuring accurate cuts and perfect surfaces for the allograft to sit against. That massively improves the chances of healing and provides rotational stability.
Technology making a real difference there.
Absolutely. And perhaps the biggest practical insight was the realization that all previous cement must be removed. They found that retained cement fragments were a major nidus for persistent infection. So now there's very strict protocols involving special tools, burrs, flexible osteotomes, sometimes even carefully splitting the bone temporarily to ensure every last speck of cement is gone. Finally, the whole approach became highly customized. Each revision is tailored to the specific patient's defect, optimizing how the implant fits with the bone and any graft, aiming for that robust biological union. This meticulous, multifaceted approach has dramatically improved success rates.
It sounds incredibly painstaking. So when you're actually in the operating theater for one of these complex revisions, what are the non-negotiable technical points, key strategies?
Several things are critical. Patient positioning. We favor the lateral decubitus position, patient lying on their side. It gives excellent access to the elbow, allows the arm to be moved freely, and importantly, makes it easy to harvest bone graft from the iliac crest or a soft tissue flap like the latissimus dorsi from the back, if needed, without repositioning.
And tourniquets, usually standard for limb surgery.
We tend to avoid routine, prolonged tourniquet use in these cases. They can be very long operations, potentially exceeding safe tourniquet times. Plus, you often need wide exposure, including identifying nerves like the radial nerve, which doesn't appreciate being ischemic for hours. Meticulous hemostasis without a tourniquet is often preferable and safer in these long, complex revisions.
Soft tissue handling must be vital too.
Paramount. Protecting the skin, ensuring good vascularity, planning for closure, it's all crucial. We might use local muscle flaps, like rotating the anconeus or brachiourdalis muscle, to cover the implant and provide healthy tissue. If the local options aren't good enough due to previous scarring or radiation, then we don't hesitate to bring in plastic surgery colleagues for larger pedicled or free flaps, like a latissimus flap. Good soft tissue coverage is absolutely essential to prevent wound problems and recurrent infection.
And the triceps muscle, getting that working again must be key for function.
Absolutely fundamental. You need a functioning triceps for elbow extension power and stability. We carefully preserve its attachment if possible, or meticulously repair or reconstruct it. Often we need to augment it, especially if it's damaged or attenuated. Using an allograft, like an Achilles tendon graft, can be very effective to restore the connection to the olecranon and provide a strong lever arm. The older VY-plasty technique is generally avoided now, as it can compromise the muscle's blood supply.
And that vulnerable ulnar nerve, how do you manage that safely amidst all the scar tissue?
Vigilance is key. The principle is to find the nerve in healthy tissue, usually proximal to the scarred area, and then carefully trace it down, dissecting it free. Releasing the medial intermuscular septum often gives it more mobility. Whether to transpose it anteriorly, move it to the front of the elbow is debated, but is often necessary if the nerve is already symptomatic, if there's significant scarring tethering it, or sometimes just to allow better implant positioning. External neurolysis, just freeing it up without transposition, is another option. Protecting it is non-negotiable.
Right. And finally, the central issue, managing the massive bone loss itself. What are the main tools in the toolbox for that?
This is where the advanced planning really pays off. We have several options depending on the scale of the defect. We can use morselized allograft, essentially bone chips packed into contained defects. For larger structural gaps, we might use bulk allograft, larger pieces of donor bone, often shaped using those 3D printed guides. Then there are the allograft prosthesis composite constructs we talked about, integrating a structural graft with the implant stem. For the most extreme, non-reconstructible defects, a megaprosthesis, a large custom-made implant that replaces the entire missing segment, might be the only option. And occasionally, if an existing implant is well fixed but needs revising for another reason, like bushing wear and there's no infection, the cement-in-cement technique can be used, putting new cement inside the old mantle to avoid disturbing well-fixed cement. The choice depends entirely on the specific defect and the quality of the remaining bone.
Such a range of complex options. So given the different ways elbows can fail, the treatment pathways must vary significantly too, especially when infection is involved.
They do. The strategy is dictated by the failure mode and whether it's acute or chronic. Let's take infection. If it's an acute infection, say within the first few months of the primary surgery, the implant is usually still well fixed. Often there's bushing wear involved too. In that scenario, we might attempt debridement, antibiotics, and implant retention.
So clean it out and keep the implant.
Essentially, yes. Thorough washout, maybe exchange the bushing if it's worn, and a course of 5 antibiotics. It works reasonably well for acute cases, maybe 60–65% success, but its success rate plummets down to maybe 30% if you try it for a chronic infection. The timing is critical.
So for those chronic infections, or if DARE fails, you need a more definitive approach.
Absolutely. For chronic PJI, the gold standard, the most effective strategy by far, is the two-stage revision. Success rates for eradicating infection are up around 90% with this method. Stage 1 involves removing all the implants, all the cement, all infected tissue, putting in an antibiotic spacer, and then giving the patient weeks of targeted 5E antibiotic.
A big undertaking.
It is. Then, only once the infection markers are down and things look quiet, you go back for stage 2, implanting the new prosthesis. It's tough on the patient, 2 big operations, long recovery, but it offers the best chance of cure for chronic infection.
What about failures that aren't infected, like simple loosening or some fractures?
For straightforward aseptic loosening, or for those type IA2 paraprosthetic fractures where the implant is loose but the bone stock is reasonable, a single-stage revision is usually the way to go. Remove the old stuff, address any bone defects, put the new implant in, all in one go. It's more efficient for the patient. It's worth noting, though, that even if you attempt a single-stage revision for what turns out to be a chronic infection, the success rate is much lower, maybe 65–70%, compared to the two-stage.
Underscores the importance of diagnosing infection properly beforehand.
Precisely. And then there's the final fallback, resection arthroplasty. This is reserved for truly dire situations. Multiple failed revisions, infections that just won't clear, or absolutely catastrophic bone and soft tissue loss like those really bad Mayo I3 fractures. You remove the implant, often quite a bit of bone, and essentially leave a gap, creating a flail elbow.
What's the function like after that?
Function is generally poor in terms of strength and stability. Patients might need a brace, but it can be very effective for pain relief and, crucially, for finally getting rid of a persistent, debilitating infection. It's a true salvage procedure, a last resort, but it can significantly improve quality of life when all else has failed.
It's clear the pathway has to be so carefully chosen. Thinking about outcomes now, how do you actually measure success after such major reconstructions, and what's the recovery journey typically like for patients?
Measuring success has definitely become more patient-focused, which is great. We still look at surgeon assessments, range of motion, x-rays, of course, but we increasingly rely on patient-reported outcome measures, PROMs. These questionnaires ask patients directly about their pain, their function in daily activities, their satisfaction. It gives a much more rounded view.
And what do those measures generally show?
The good news is that, despite the complexity, outcomes are often significantly improved. Systematic reviews suggest around 78% of patients report good or excellent outcomes after revision TEA. We see big jumps in scores like the Mayo Elbow Performance Score, or MEPS. I've seen series where the average MEPS went from about 30 pre-op, which is very poor function, up to the mid-80s post-revision. And graft incorporation rates, when allografts are used, can be over 90%. In terms of motion, the goal is usually to achieve a functional arc, typically aiming for 30 degrees extension to 130 degrees of flexion. That allows most daily activities.
Those are genuinely impressive results, given the starting point. Can you share a patient example that really brings that journey to life? Maybe someone who was facing that last resort scenario.
Yes, there's a case that really sticks in my mind. A 53-year-old scientist, background of juvenile rheumatoid arthritis. He'd had a primary TA years before, but then developed a nasty surgical site infection 15 years later. He'd already been through eight failed operations elsewhere trying to sort it out. He came to the specialist center, essentially believing amputation was his only option left.
8 failed operations. That's devastating.
It was, and the damage was immense. He had lost 10 centimeters of his humerus, half his ulna was gone, multiple fractures, just catastrophic bone loss, chronic infection, a non-functional limb. Dr. Mark Morey took on the case. The surgery involved incredibly meticulous removal of all retained cement, which was present from the previous surgeries, highlighting that point about residual material harboring infection. Then, radical debridement, antibiotic cement application, and reconstruction using a structural allograft combined with the prosthesis.
Using those 3D guides you mentioned.
Exactly. 3D printed guides were used to prepare the bone ends perfectly for the allograft, maximizing contact and stability. They also used an allograft to reconstruct the triceps attachment and chose a specific implant type with roughened surfaces designed to encourage bone to grow onto it. It was a belt and braces, highly customized reconstruction.
An incredible undertaking, and the outcome for him.
Quite remarkable. Just 3 months after that massive reconstruction, his hand and elbow were functional again. He went from facing amputation to regaining use of his limb. 2 years down the line, he remained incredibly pleased, able to use his arm for daily tasks, his independence restored. It just shows that even in the most challenging, seemingly hopeless situations, these advanced techniques, performed meticulously by experienced teams, can offer genuine salvage and dramatically change lives.
That's an amazing story. It really highlights the impact, but the surgery is only part of it. What about the post-operative care and rehabilitation? That must be intense.
It's absolutely critical. Good surgery can be undone by poor aftercare. Effective pain management is key, using a multimodal approach to minimize opioid reliance. Meticulous wound care, keeping it clean, dry, protected, is vital to prevent infection. Prophylactic antibiotics are often continued for a period. Patients usually stay in hospital for maybe 4 or 5 days initially.
And the rehab starts quite early.
Relatively early, but carefully. Usually around 3 or 4 weeks, we start light, gentle exercises, focusing on aligning the healing tissues. Active range of motion exercises begin soon after, aiming for that functional Thermal 130 arc within the first few weeks, always respecting the healing tissues, especially the triceps repair and the skin. Then, as healing progresses, we gradually introduce resistance and functional training tailored to the patient's goals.
Is there a guiding principle for the rehab?
A useful concept is that the shoulder and elbow are the servants of the hand. Rehab is often driven by getting the hand working dexterity, grip, and the elbow and shoulder function follows to position the hand effectively in space. Most patients make significant gains in motion and strength by 3 to 6 months. But long-term activity restrictions are crucial. We advise patients to avoid heavy lifting, repetitive impact, contact sports to protect the implant from loosening or fracture. Although realistically, we know some patients, perhaps up to 40%, do push those boundaries.
That must be a difficult conversation. Even with optimal care, complications can still happen during recovery. What should clinicians be watching out for?
Yes, vigilance is always needed. Persistent deep infection remains the big worry, especially after single-stage revisions for presumed aseptic loosening that might have had unrecognized infection. We know the risk factors: S. epidermidis, multiple microbes, patients on steroids, massive bone loss. If infection does recur, it often means more surgery, potentially leading to that resection arthroplasty. Nerve injury is another risk. Ulnar or radial nerve palsy can occur, sometimes from cement leakage, surgical traction, or even compression from fixation plates. Thankfully, many of these recover over time. And lastly, symptomatic hardware, like screws or plates used to fix fractures, can sometimes cause irritation and need removal later on once everything is healed.
So the journey requires ongoing monitoring. As we draw this deep dive to a close, what are the ultimate key messages for clinicians dealing with or referring patients for revision elbow arthroplasty, especially these complex cases with bone loss, and what does the future hold?
The main takeaway is that revision TEA, especially with major bone loss, is a deeply complex multifactorial challenge. There are no simple answers. Success hinges on a really methodical, comprehensive assessment looking at the bone, the implant, the soft tissues, the nerves, and ruling out or treating infection, followed by a surgical strategy that's meticulously planned and tailored to that individual patient's specific problems.
Which strongly implies these aren't cases for everyone to tackle.
I think that's fair to say. Ideally, these highly complex revisions are best managed in specialist centers. Surgeons in these centers have the necessary experience, having dealt with a high volume of these challenging cases. They also have access to the full range of implants, advanced technologies like 3D printing, and the multidisciplinary support needed. That concentration of expertise really does make a difference to outcomes.
And looking ahead, what innovations are on the horizon?
The field is constantly evolving. There's ongoing work on implant design, aiming for better longevity, perhaps different bearing surfaces, improved fixation. New materials are always being explored. 3D printing is becoming increasingly sophisticated, moving beyond just guides to potentially printing custom implants matched perfectly to a patient's defect. We're also getting better at understanding patient outcomes and identifying risk factors, which helps refine who we operate on and how. And perhaps further out, advances in managing conditions like rheumatoid arthritis might even reduce the number of patients who develop end-stage elbow destruction in the first place.
That would be a fantastic development. So, a final thought, or perhaps a call to the wider orthopedic community?
I think the key is collaboration and continued learning. Sharing knowledge between specialist centers and the broader orthopedic community is vital. Experienced centers are usually very open to discussing complex cases, offering advice, perhaps via video consults, and accepting referrals when appropriate. The ultimate goal is to ensure that patients everywhere can benefit from the best possible expertise and achieve good outcomes, even for these incredibly difficult elbow problems.
That's a great note to end on. This has been an absolutely fascinating and incredibly detailed exploration of a very demanding surgical field. Thank you so much for sharing your expertise and insights with us.
My pleasure entirely. Thank you for the discussion.
And to you, our listeners, we hope this deep dive has given you valuable insights into the world of revision total elbow arthroplasty. It's worth reflecting on the profound difference mastering these techniques can make restoring function, independence, and quality of life for patients who might otherwise have very few options left. These aren't just technical exercises, they are life-changing interventions. If you found this deep dive valuable, please do take a moment to rate and share our deep dive with your colleagues.